As the chairman suggested, it's a very interesting topic because we see a complexity in surgery on the one hand, but also a complexity in basic science on the other hand. And the question is, can we still combine them, and why should we combine them? My answer is definitely we should combine them even more than we did before, in my opinion. So when we go back to, for example, the topic of cancer, when we look at all the developments since the beginning of 19th century in the science field, especially in the cancer research, we see that the developments have all been made thanks to basic science. It starts with the cellular origin of cancer. It starts with the causes of cancer, like viral causes, chromosomal alterations, then deciphering the structure of DNA, the discovery of oncogenes, sequencing of human genome, and so on and so on. So the development in cancer research comes from basic science, which is what basic science is the main pillar of cancer research on the one side. But on the other side, cancer research can be divided up into basic cancer science research, but also clinical cancer science research. And all these are intertwined and interconnected. One is not independent from the other, which is good, which is the way it should be, I think. But there is a tendency to think that these things might be separate. And I think that's a basic mistake. And the question is actually, does basic science, which is a huge domain, which gets complexer, and which is the basis of cancer research, does basic science still need surgeons, or does it not need surgeons anymore? So let's look at some titles of some commentaries that have been published about surgeons and science in the last decade. And you see that there is a growing fear of the extinction of the species of surgeon scientists, that there are fewer and fewer surgeons among us who perform science. Look at these titles, A Dying Breed. This is a very emotional, actual way to express this term. How to ensure the survival of the surgeon scientist. So there seems to be a problem, and we should really profoundly think about why it is like this. And now look at the numbers here on the left hand. You see the funding that is allocated to scientific research in surgery. In the middle, you see the number of basic science abstracts submitted to the American Society of the American College of Surgeons Congresses. Here you see that there is a prominent drop in the number of abstracts submitted, but also in the amount of funding that is allocated to science. Only 2.3% of all grantees in basic or translational science are actually surgeons. And we see that there is a reduction of 1/4 in the basic science abstract of surgeons submitted to congresses on this topic. So why is it like this? If I may come back to one of my first sentences, there is an increase in complexity. This complexity relates to our surgeons having a higher clinical workload. But we should think about this once again. Did the surgeons 2 decades ago really work less than we did? Is that the case? Do we have more administrative duties? We have many administrative duties, but is it really more than when it used to be 20 years ago? Work-life balance, yes, this is of course a hot topic nowadays. But is it really all? Is it really what matters most? And the increasing complexity of science, which is certainly a key aspect, what might explain some aspects, but not all aspects in my opinion. And this survey showed that 70% of all academic surgeons in USA believe that a surgeon cannot have a successful basic science career, which is very worrisome. And I do not believe in this statement personally. Because when you look at cancer treatment, the majority of cancer patients still need surgery for their treatment. Surgery is one of the mainstays and one of the main pillars of treatment in cancer patients still. And I also would like to emphasize that when we do surgery, we also want to understand what we do. And we can, in my opinion, only understand what we do if you think about it in detail and if you perform science about it. I'd like to give to you an example from our research field. So we work on pancreatic cancer, and especially we try to understand how nerves interact with cancer. This is a growing, emerging research field called cancer neuroscience. And we know that pancreatic cancer tissues are filled with nerves that are green on this image. Many of these nerves are invaded by cancer cells, and this nerve invasion is a very prominent prognostic factor in pancreatic cancer. It's actually, in several analyses, one of the only 2 independent prognostic factors for overall survival in these patients. Patients with a high severity of nerve invasion have less than half the survival rate of patients who do not have any nerve invasion. So this has long been believed to be a correlation, but there came then some basic science studies that use mouse models. The mouse models, although they are not human, still yield important results for, I think, our understanding of this disease. And they perform a denervation where they interfered with the signaling of cancers to the sensory nerves, and they have seen that the mice live longer. So they could prolong the survival of mice by just denervating them, or let's say cutting the sensory nerves of these mice. So this was an interesting observation, because when we think back about the surgical aspect, when we deal with pancreatic cancers that deal along these major vessels, these vessels are the places where the nerves sit. And there is first of all, a very close anatomical relationship between pancreatic cancers and the nerves. And we know that when these vessels get infiltrated, like the portal vein, superior mesenteric vein, or the arteries, it's not always the artery lumen itself, but it's of the vessel, the nerves around these vessels that are infiltrated. So it is in one sense no wonder that these patients have extensive perineural invasion. But sometimes we perform surgery for hours and hours and hours, and the patients still get local recurrence. And this local recurrence usually happens around these major vessels like celiac trunk. So when we see these recurrences, we say, oh, there is tumor tissue left there, but why is it left there? Did we operate so badly? Maybe we have a standardized procedure, we do the same surgery every week, and then some patients get recurrence, others don't. Why is it like that? Because when we have a closer look at these tissues around these vessels that have nerve invasion, we see that these that have this vascular signal here. This is actually sites where these cancers have nerve invasion. The cancer cells recurred there because there are nerves there that had hidden the cancer cells around them as an extra pancreatic neural invasion. So let's take it one step further. Let's say we perform this type of surgery where we clear up everything, right? We take out all these vessels, all these nerves around these vessels, all the soft tissue, this triangle operation that has been beautifully introduced into the literature. So we might be happy and say we did the perfect surgery, so I can go home and say that I'm an excellent surgeon and have a perfect performance. But I think it's this step where we should again go back and ask ourselves, are we doing the right thing? Are we doing it sufficiently? Or how can we improve the outcome for the patient? We analyzed the ganglia that are placed on both sides of the aorta, the celiac ganglia, and looked what do they look like in these cancer patients. And what we have seen is that all the nerves in these ganglia or neurons are green, and you see these red cells here that are distributed here, diffused around them. These are all cancer cells. Even if we take out all the soft tissue there, as excellent surgeons with perfect technique, with artery resection, the ganglia still contain cancer cells. So we are trying to solve this problem from a Don Quixote perspective, where we are trying to beat an enemy which is much more ahead and much more advanced and progressed than we think. And when we look at these vessels that we resect in surgery more closely, we see that the cancer cells are not that much interested in going into the lumen of these vessels, not because they want to have a hematogenous spread there by invading the vessel wall, but they are interested in the nerves that are around these vessels. And we've seen that when there's a vessel invasion, it's actually the nerve on the vessel that is invaded, and it's the perineural invasion that leads to the artery wall infiltration or venous infiltration. So how can we increase the benefit of surgery if nerves are invaded so early and already extrapancreatically? And honestly, let's go to the lab and ask the biologists, I'm sorry, but how should they come up with this question? How should they make this observation if we do not help them, if we do not communicate this to them? Because they will never be able to know that this is a clinically relevant problem. We will do the surgeries, but they will not know about it. And this is why we have to have a good understanding and experience in basic science so that we can efficiently talk to them in the same language, I think. And to answer for such questions, we need experiments and good experimental models. And we can contribute to the development of experimental models because from one perspective, we know this disease better than the oncologists and the biologists because we see it directly every day in the patient in front of us. We try to challenge this disease. We try to take it out completely at once. There is one mouse model of pancreatic cancer, the so-called KPC mouse model that I briefly mentioned at the beginning with the denervation experiment. When we looked at these mice, we saw that they do not have any nerve invasion at all. But this has nothing to do with the human disease. If we do not communicate this to the researchers, how will they know that? But the better thing will be we take the initiative and develop the actual models that are more human-like because we are the ones who know this disease better, in my opinion. And we therefore develop, for example, a mouse model which has human-like nerve invasion, just just like the images that you see here in the human disease when there's perineal invasion, and the pathologist confirmed that this is human-like nerve invasion. And we could do this by analyzing the current mouse models and the mutations that are present in the widely used models, and generated new mutations, new combinations, and then thereby could contribute a new model to the literature, which is more similar to the human situation. And this is just an example of how surgeons can contribute to advancement, I think, in the science field, because we have a unique knowledge of the human disease. And this knowledge, in my opinion, we do not use sufficiently and, let's say, efficiently enough. So the role of the surgeon scientist in cancer research should be multifold. So if you look at these polls where there is a scientific principal investigator who is interested not only in clinical science, that means performs research not only in surgical techniques, but also in basic science, this principal investigator will be able to design the actually clinical relevant studies for the basic science field. When it comes to new medication therapies, when it comes to new understanding of pathophysiology, this principal investigator with a clinical background will be able to design the best studies. And as you might agree, the scientific quality is best measured by the quality of the question that you ask. And we have the capacity to ask the best questions, I think. We should not be the providers of patient probes for research. I think this undergrades what we have learned, what we do on a daily basis, and most importantly, what we can do if we use all our capacity and try to provide the best support for the science field. So what are the perspectives for generating a new path for the future of surgeon scientists? I think we need to think about the narrative of surgeon scientists once again. Surgeon scientist is not a surgeon who is doing science by side, let's say, couple hours per week and so on. No, science should be derived from our daily work, and science should be an integral part of our daily work, because this is the only way where we can, or let's say how we can advance this field in an efficient manner and how we can accelerate progress in this field. Financial opportunities are extremely important. I know that on all parts of the world, be it Europe, United States, also Turkey, this is a growing problem because research is getting more and more expensive. The financial opportunities overall are not as much as they used to be, and for surgeons they're also not much. But this is just an example from Germany, where they have now, the German Cancer Aid has initiated a call on operative surgically oriented research studies, which is an excellent initiative, I think. And I believe that such initiative will now be initiated in other countries, both in Europe but in the United States. And surgeon scientist programs are more important than ever because, as I said, science is getting more and more complex. We need more complexity for analyzing the data. We have multi-layered data that we now have to integrate. We will need AI, artificial intelligence, for this very soon, it looks like. And this all is only possible if we educate in a very early phase. This is an example of a suggested surgeon scientist program which is integrated in the general surgery training. Here are the postgraduate years of training. Typically, if you only work clinically, you will be able to conclude it in 5 years, but by integrating research in a structured way, these young surgeons can get good exposure to science. At least 2 years of dedicated, protected research time might be sufficient for you to have a very good understanding of science and to generate the basis of your future scientific work. And it's very important that I think when we look at the whole scene of research that is running basic science or science overall, you see that multiple partners are interacting already. They are gathering already around these questions, and this cooperation or this collaborative interaction works very well. All these people make major contributions to this field. And as I said, they are dealing with a disease that we treat on a daily basis, all of you. So why should we really exclude it from this interplay? We should be quite central in this interplay because we surgeons need science for understanding and improving how we do surgery, what we do on a daily basis. And on the other hand, basic science needs us surgeons for asking the right questions and generating the right models. And this interaction will only be possible if we surgeons, A, have an excellent education in basic science to the extent that is possible, and B, if we believe in the importance of basic science for our field and for advancing science. Thank you.